Cindy, your questions.
Okay. Thanks for that wonderful introduction, Doctor. And my question kind of has to do with the newer therapies, the newer immune therapies. I know there's a lot of excitement around them, the CAR T-cell therapies for the high-risk myeloma. But right now, I guess the most aggressive type of therapy we have for high-risk myeloma is the allogeneic transplant. Where do you see that fitting in now with the newer trials going on? And I know there's a T-cell depleted transplant at Memorial Sloan Kettering. Would that be something a high-risk patient would want to consider?
Yeah, so you're asking me whether I see a role for allogeneic transplant and for the depleted T-cell approach linked with the allogeneic transplant, if that has a role now and in the future. Is that the question you're asking me?
Right, exactly.
Well, I do think that allogeneic transplant for many years has been abandoned in the field of multiple myeloma because the results were not very promising, and also the toxicities and the risks were very, very high. But there are a couple of groups that have continued to see how allogeneic transplant could be improved, and working with the conditioning approach, the therapy that was given before the cells were transplanted, and also how the modulation of the immune system was handled. That has been worked on, and there are a couple of groups that have really done a lot of work. I do think that there is no data coming out, including, you mentioned here at Memorial Sloan Kettering, there are other groups as well, but there is data coming out from this new work showing that the risks can be significantly reduced with these additional procedures and tweaks in the processing and in the management and the deliveries of the T cells. So the graft versus host disease that has been a major problem in the past can be majorly reduced and extremely reduced. And the risks also by the therapy have been majorly reduced by the conditioning therapy. So I do think from where we are at this very, very moment, until the CAR T-cell therapy has been fully evaluated, and it unfortunately may not work, but it could very much work, and I hope it will work. If it will work, that will become a major player, but at this point, that's too early to say. So it's something that needs to be explored. And also these other therapies I mentioned have not been fully evaluated in high-risk disease. So I do think that given where we are right now, for someone who has high-risk disease, if other therapies do not work, I do think that an allogeneic transplant in the setting of modern T-cell support and modern conditioning done at a top-notch center, I do think is a very, very reasonable option to consider. The key question for many patients who are asking this question, even when you hear that it's much safer and it's much better than it used to be, is still the question that comes up is, are there any other options I should consider before I do it? And what would those options be? And if I pick these other options, if they work, that's fantastic, but if they don't work or if they stop working, will I still be a potential candidate for this allogeneic transplant? And these are very difficult questions to know for each and every patient ahead of time. So I think for patients who are on the verge of not being candidates, but they are candidates for the allogeneic transplant, if that is something that individual is potentially interested in, I think the timing issue is probably even more important, and maybe to pursue something else may potentially risk the opportunity to have the allo if that's not something that the individual patient chooses to do as a rescue. So to not do it could, worst case, mean that it will not be something that can be offered due to safety reasons. But for a patient who is in better shape, who wants to explore something else, I see that there are patients that go for other therapies and they try that and they explore that, and then if that works, that's very good, obviously, but else coming back to the allogeneic transplant could be an option for that individual patient. So these are very, very, very difficult situations, and usually we spend a lot of time going through the individual patient's biology, looking at prior therapy, response to prior therapy, the duration of that response, the depth of that response, toxicities and organ function in general, and being very, very transparent and show all the data, all the pluses and minuses, usually is being very clearly demonstrated and discussed between the doctor and the patient, and then each and individual patient will have to make the decision what is the right thing for he or for she. These are difficult, very difficult questions.
Yeah, it's a very difficult decision. I guess it's very individualized depending on the patient and what stage of disease and what their features are. So thank you. And my second question, I hear a lot of talking now about continuous therapy versus a fixed duration of therapy. Would you recommend a continuous therapy for a high-risk patient, for someone just to stay on therapy until they progress, or if they achieved a complete response, for them to get off of therapy? And how do you envision MRD testing in the future to help make this decision?
These are also very, very good and very difficult questions. So at this moment, there are a couple of things that have been addressed in studies that we know the answer to, and there are a couple of questions we can ask where we don't know the answer. So let's try to do this in a very rational fashion here. So what has been shown across the board with more than 20 published studies, independent of what technology and what assay has been used, if a patient reaches minimal residual disease negativity versus reaching a complete response with MRD positivity, statistically speaking, progression-free and overall survival is longer in the individuals that are MRD negative. There is also data showing that MRD negativity, you can have different measures of sensitivity, that for every step in the more sensitive direction, and we use logs, so it's a 10-fold or 100-fold or 1,000-fold, etc.-fold more sensitive assay. For every 10-fold improvement, that translates into longer survival. So deeper responses seem to be preferable if that's possible to achieve. Of course, it has to be in the light of toxicity. If someone cannot really reach it and you just keep on pounding with therapy, it may still not respond, but you just add a lot of toxicity. So it has to be done in the light of all other aspects. But if we assume that it's possible to reach it with reasonable therapy, that would of course be the preferable outcome. Now, for high-risk disease, there are studies showing that if you reach a certain level of depth of MRD negativity, if you have standard risk or high risk, there is data to suggest that the duration of that maintained MRD negativity is shorter if you don't have any maintenance therapy. There are also some data, now the information is much more sparse because there are very few studies have really looked into this in a systematic fashion, but there is data to suggest that even in maintenance therapy, that probably is a true statement that the high-risk biology still has a little bit more of a tendency of coming back versus the standard risk over time. Now, what's not known is whether you adjust the therapy, if you could quantify the MRD negativity, if it turns MRD positive, if you were to increase the therapy, the intensity to bring it down to MRD negativity again, and then continue monitoring. So these are things where we don't know the answer. So these are kind of the principles. So based on this, my interpretation and my recommendations that are based on data and my experience, so there are many pieces of data that we simply don't have the answers to specific questions. You have to just use your clinical judgment. So my interpretation and my recommendation on average would probably be to keep some maintenance approach for both actually standard risk and for high-risk disease. And that would be based on the fact that there are studies showing if you stop the maintenance therapy, that the disease has a shorter time to returning. Now, it has to be given in the light of toxicities. So I would probably do maintenance for both those two groups as my default, and there could be deviations for that for individual reasons.
Thanks a lot, Cindy, for those questions. I appreciate it.
And thank you, Doctor.
You're welcome.
Pat, are you online with your question?
I'm here, Gary.
All right.
Doctor, could you explain how the exciting new T-cell therapies work? I know that the myeloma crowd, our group is going to support two research programs that both use different types of T-cell therapies. Could you just take a moment and explain how that works? And I know some of them are used with a transplant and some aren't. And could you just shed some light on that for us?
Yeah, so the principles are such that you can characterize cells throughout the body, and you can look either on the inside, you can look at the genetic signatures of cells, and you can also look on the outside of cells, and you can characterize their protein repertoire, if you want. They have proteins on their surface. And if you look on the inside, if you look in healthy throughout the body, most of the cells in the body look very, very, very similar genetically. It's because the DNA in our bodies is very, very similar. It comes from our mother and father, and most cells, independent of origin, have the same genetic content. When a disease of a malignant type develops, such as multiple myeloma, that's an outgrowth of, in this case, plasma cells. That belongs to the immune system, the white cell category. They also have very similar genetic content to all the cells in the body, and they are, of course, very closely related to the normal plasma cells in the body, but they have certain genetic changes inside that make them exist. We don't really understand what goes wrong, but something goes wrong, and then all of a sudden they are there. To try to direct therapy after these genetic changes is it's very difficult because they don't look exactly the same, all the myeloma cells. So instead, people looked at the surface of the cells. And then if you look for markers on the surface of these cells, what you want to make sure is that you don't have the same proteins on the surface of other cells. You could theoretically have that in any other organ throughout the body, the lungs, the kidneys, the liver, the eye, the skin, the bone, everywhere. So a lot of work first has to be done to determine what proteins do myeloma cells express on their surface that are unique to them and you don't find elsewhere. So a lot of work has been done, and it's not 100% clear which is the perfect protein to go after. And the reason I spent some time talking about this is because this is a huge part of the research. Which of the proteins shall you pick as your target? And it may sound easy, but it's very difficult. And to make it very simple, there could be proteins that are not expressed on every myeloma cell, or there could be proteins expressed on every myeloma cell, but they could also be on other tissues. And there could be proteins that if you go after them, then the cells maybe down-regulate them, so they stop expressing them temporarily, so then the therapy wouldn't work. So there are a lot of possibilities here, and there's so much research that needs to be done to fully understand this, and there are a lot of unknowns here. But the basic principle is that you look for these proteins on the surface of the myeloma cells. And then we know that the immune system has a lot of subsets of cells that are designed to go after structures that enter the body. And the outgrowths of these malignant cells, the bad plasma cells, they do express markers that I'm talking about here, proteins that you could tell other parts of the immune system that these are not supposed to be there. Please, can you take them away? So you hook up the individual person with a device, and then you suck out T cells that are in the body. And then you expose these T cells to something called vectors that make these T cells develop structures on their surface that are the counterpart of these proteins that you now have identified on the myeloma cells. So if you give these lymphocytes back, these T cells back in the bloodstream, when they enter the bloodstream, they will go into the blood and they will find these proteins that they are designed to identify. And when they bind there, then they will trigger a cascade of immunological events. And you basically will have the immune system eradicating the cell that this T cell now has attacked, if you want. So in order to do this, if you just take out these T cells and give them back, the first thing that will happen is that the body will say, hey, wait a second, even if these T cells are my own, they don't look normal. So the body will try to destroy these CAR T cells. So you need to suppress the immune system a little bit in order to do that. So you can then do an autologous stem cell transplant first, and then you give the T cells. Or you can do chemotherapy and then give back the T cells. So you basically deliver these T cells in the setting of a little bit of a suppressed immune state. You don't want to have complete suppression because then you won't have the effect. And even if you suppress it, you want it to recover so these immune effects then can take place and take out the bad cells, so to speak. So I try to outline here that there are a couple of areas of development. One is to pick the right proteins, and you may have to have CAR T cells that go after more than one, and this is not really known, but the field is going in the direction of having more than one, maybe. And also, what is also under development is what is the perfect type of therapy to deliver these cells. And different groups have done different things. Some groups, they do the autologous stem cell transplant. Other groups, they do the chemotherapy. And there are different opinions about this. So these are like the basic principles.
That's probably the best explanation I've ever heard. That helps a lot. And no, none of it sounds simple to me. I had this image of someone sitting there with a microscope trying to change change these cells before they were put back in the body. So that helped a lot. And so obviously there are a lot of speed bumps here. How close do you think we are to having these therapies that are really, that you can count on, that are really going to work?
Are we talking about CAR T cells?
Right.
Well, so there are currently 2 trials that have been opened. And the first trial that opened at the National Cancer Institute in Bethesda. And this was by Jim Cockendorfer, that came out of Steve Rosenberg's group. Steve Rosenberg is probably one of the biggest cancer immunologists at all times. He has done a lot. So Jim did work in Dr. Rosenberg's laboratory, and he looked for these proteins that I was talking about, and he identified a protein called BCMA that's expressed on the myeloma cells. And Jim showed that in mouse models that they could deliver these CAR T cells, and they could have very good eradication of these myeloma cells in the mouse model. So that led Jim Cockendorfer to develop a clinical trial, and it opened at NCI I think 6 to 12 months ago. At this point, they are still doing a phase 1 trial, so they are trying to identify how high of a dose of these CAR T cells they need to give in order to have effect. And at this point, to my knowledge, this study is still ongoing, and the exact dose has not yet been determined. And they basically have not finalized the study, and it's ongoing, and they are trying to increase the dose to see if they can find the optimal dose to have responses. The second study that was developed at the University of Pennsylvania by Dr. Carl June, who is also one of the big leaders in the world for cancer immunology. Carl June, he did a study using CAR T cells for lymphoma a couple of years ago, and now he decided to take his lymphoma CAR T cells. So he was on purpose not looking for proteins that were expressed on the surface of myeloma cells. So he did a completely different thing. So he said, why does myeloma exist? And he said, myeloma cells are what's called very late stage B cells, and they cannot proliferate. They cannot get more of them. They have to come from somewhere else. I think he said that they are probably originating from B cells, earlier stages of B cells. So he said, I'm going to take one of these CAR T cells that I developed for lymphoma and give that to patients with myeloma and see if I can actually see responses there. And he presented this at ASCO and the European Hematology Association meeting in June in this year. And there were only 3 patients that were initially treated. And the first patient had, I don't remember the order of them, but there were 3 patients. One of the patients had no effect and unfortunately had the disease coming back right away. The other one had, I think, a little bit of an effect, but it didn't last. But then there was another patient whom I think had a very good response, and it seems to be very durable. So at this point, they are now trying to dig deeper into this individual who had this very good response, and I think that's a very interesting observation, because it's not only addressing the issue of CAR T cells, it's also addressing the way of going after the disease, not going after the plasma cells directly. So I think that's a very interesting approach. And lastly, so there needs to be much more work done for both these 2 studies. They are very, very early. It's based on one patient, the University of Pennsylvania. One is simply only one, so it's way too little to know for sure. What we are doing here at Memorial Sloan Kettering is that we are working on multiple targets that go both after myeloma cells and B cells. And we are developing strategies where we have integration of these 2 models. And we think that we will probably open our first study around the summer of 2016. So our program is heading very, very fast forward, and we We believe that both these models are important. We are not using the same targets that these two studies have done, but we have identified targets we think are maybe better, but that remains to be proven.
Thank you, Doctor. That's really helpful. Gary?
Yes, thank you, Pat. Doctor, we've run over a little bit. We do have a little extra time for some questions from not only Jack, but some of our listeners as well. Doctor?
Yes?
Do you have a little extra time?
Yeah, I can do a few more minutes, but then I unfortunately have to wrap up. I have to prepare for a talk. I'm going to Europe tomorrow.
Okay, well, thank you so much for a little extra time. We really do appreciate it. We know how you're stretched for time. Jack, your question, please.
Sure. Dr. Landgren, thanks for being available to us. The research is really exciting, but if I'm a patient today and my doctor says I have this high-risk factor that he calls deletion 17p, does the initial induction treatment of that patient differ from a non-high-risk patient?
So now we are talking a little bit about how do we define high risk in the clinical setting of 2015. So myeloma, as I said, has very many different types of disease within a given patient and across patients. If we apply these very superficial tests that we have been using for many years, such as cytogenetics and FISH, we can capture 17p deletions in probably 10% of individuals that are being newly diagnosed. It has been found in several studies that that disease could be more active and could be harder to get full control over. So it would, in the clinician's mind, and I agree with that, impose that more effective therapy should be given. And the standard approach typically would be to use a 3-drug combination with therapy. Usually a proteasome inhibitor is included in combination with steroids, and either it could be a immunomodulatory drug or cyclophosphamide. Those are probably the combinations that many or most centers in the United States would use. It should be mentioned that most individuals who have these deletions, 17p, that there is actually all patients who have this, there is a gradient of the penetrance of these deletions. So these deletions could be present in every cell, or it could be present in a small subset of the myeloma cells. There are several studies showing that if only a small proportion of the cells have this deletion, that the impact of that deletion may not be there. It may be very similar to not even having it. And there's a little bit of a controversy there. There are some studies showing if you have less than 30%, and some studies say even if less than 70% of the cells have it, that would be the same as not having it. So it's not entirely clear. It's controversial. But I do think that most centers would recommend a 3-drug combination for individuals who do have it. But again, having it may or may not carry the same weight depending on these reasons.
And would you prefer that same 3-drug regimen for a patient that doesn't have those factors?
So that's the other question, and I'm glad you asked that. So I do believe that until there is an established curative therapy, I personally think that until there is data to show the opposite, I think that the best therapy should be given to every single patient. And I will not cut back on therapy until there is a cure, unless there is toxicity. So there are several studies showing that for patients who have the standard risk, that would be not, for example, having this deletion or other such findings, that if patients who do not have it are receiving the 3-drug combination, then their outcome is better versus if they only get 2 drugs. So, in my opinion, every patient should be offered a 3-drug combination unless there are contraindications or other reasons. That would be my default. And there is no data to support the use of 2-drug. That is pure opinion-based treatment strategy. So this whole business with what's called risk-adapted therapy, I don't believe in that, and there is no hard data to back that up.
Thank you very much.
Thank you, Jack. Appreciate it. Priya, could you check online to see if we have any questions? And Doctor, after you've answered a question, whenever you find that you have to leave, just let us know and we'll wrap it up. Okay?
Yeah. I think I can take one more question, and then unfortunately I do think I have to return. I have to finish my slides.
Okay.
Thank you,
Priya?
Gary. Listeners who have a question for Dr. Landgren, you can please press 1 on your keypads and we can bring you live on air. Dr. Landgren can take only one question. We are already over time. Yes, the person calling in from 408-832-9005. You may please ask your question.
Yes, my name is Srihari. The question I had was, if a patient gets to very good, like almost even an MRD negative kind of a response, I think you just mentioned that continuing maintenance might be appropriate. Is there any data about using, say, some more consolidation of a slightly different triplet from the induction regimen, which might help with ensuring probably a deeper response that is much more durable?
So I had a hard time hearing the very last few sentences you said. I think I heard you said that if you reach MRD negativity, and then I couldn't really hear.
Yeah, is there any data about probably instead of just maintenance therapy for really extended periods of time, say a triplet-based consolidation just for a few months or so, few cycles, of a slightly different regimen from probably the induction regimen? In the literature, I found very little information about consolidation other than probably the stamina trial and probably one VTD kind of information.
So are you asking me about additional consolidation, or are you asking me about
yes,
maintenance?
Consolidation in lieu of probably really extended maintenance. The prospect of unlimited maintenance when probably something a little more short-term is quite attractive, and I'm wondering if that's a premise which is even valid.
There are so many different studies looking at different things, and there are a lot of differences how these different studies are designed. So some of the studies that use a little bit less powerful therapy, and then they have a high-dose melphalan with stem cell support or autologous stem cell transplant. Some of those studies have added additional chemotherapy or triple-drug therapy after the transplant and found that could further deepen the response. Now, if you look at patients who have received very powerful therapy, it actually seems that 4 cycles is not necessarily the number of cycles that will take the individual patient to the deepest response. In fact, there is some data suggesting that it could even be up to 6 cycles on average. Now, some patients could have 2 cycles, some 3, 4, 5 on average before they reach very deep response, MRD negativity. Why do 4 cycles usually, why does that show up? Why is that like a common number? I do think that 15 years ago, we had the old VAD therapy with chemotherapy, and one of the drugs, adriamycin or doxorubicin, that was part of that regimen, is cardiotoxic. And we did never give more than 4 cycles because that was toxic for the heart. But when that therapy was replaced by newer therapies, what happened was that the number of cycles remained the same. This is just how the logic happened, and it just happened like that. So instead of giving 4 cycles of VAD, people gave 4 cycles of RVD. But if you instead looked at the depth of the response, if you just gave more cycles, we did a study when I worked at the NIH where we looked at the number of cycles in relation to MOD being achieved, and we saw that the average time was 6 cycles. So if you forget about the history and you just look at the response, I think that 4 on average is probably too little. But there are patients, again, that reach MOD negativity already after 2 cycles. I'm not saying that every patient needs it. So given that, I think for studies that give 4 cycles, give high dose, and then give additional therapy, in my opinion, that is not consolidation. It's just like there is disease left behind and you just give more therapy. And you can call it whatever you want. If you give it upfront or you give it and do transplant and give more, it's just more therapy. So I think that's, in my opinion, is why you see these different patterns. Now, in an individual who has received a certain degree of response, and then you put the patient on maintenance, even if there is a little bit detectable disease, if you are MOD positive, so does maintenance continue to suppress the disease? And the answer is actually yes. I have seen patients being on maintenance for like 1.5 years, and then MOD negativity can be measured. I simply think that in many patients, the low dose of therapy works as an extended dosing. So in my mind, I have kind of stopped using these terminologies with induction therapy and consolidation therapy and maintenance therapy. I think of it more as combination therapy because you combine drugs, and then I think of it as extended therapy, which I think the lower intensity is. So I think like you have more combination and then you have the extended. And ideally, of course, you would like to stop therapy. So what I'm doing right now in my clinical research program, I'm leading a study I'm going to open very, very soon. We treated patients when I was at the NCI. We had programs we developed with combination therapy, and then we treated with maintenance for 2 years. We will now offer to continue on this new study that we're opening for another 3 years of extended dosing, or what people call maintenance. And we will continue to monitor for MOD negativity. And my plan is for individuals who have stayed MOD negative for 5 years, my plan will be, when that happens, will be in another 3 years to see if we can develop a new study, and I will start working on that probably next year or so, to offer people to go off or to stay on therapy with continued MOD negativity, measurement, to see if the MOD negativity can be maintained without therapy. That would be the next logical question, to see if you can go off therapy. And I don't know the answer to that, and I don't know if 5 years is right or wrong, but you have to start somewhere. So that's my next step in terms of seeing if we can start peeling back on therapy. And I don't know the answer at this point. So these are like my rational approaches to pursue these questions.
Thank you, Dr. Landgren. It has been a pleasure to listen to you. Thank you for the time. And I thank the myeloma panel, Gary, Pat, Jack, and Cindy. Thanks for joining us. This talk will be made available on Cure Talks along with the transcript. Please visit curetalks.com for details on upcoming talks. Thank you, everyone.
Thank you so much for having me. Take care.
Thank you, Dr. Landgren. You made some very comprehensive answers to some very difficult questions, and we certainly appreciate that.
Thank you very much, everybody. Enjoy the evening, and take